A healthy sex life is important at any age. However, a change in desire or painful intercourse can significantly alter a woman's sexual activity. Dr. Melanie Santos is an expert in female sexual dysfunction, and she's helped many women resume this important part of their lives. Melanie, thanks for coming.
Thanks for having me, Larry.
So we hear it all the time about male sexual dysfunction. How common is female dysfunction?
It's actually quite common. Almost 40% of women in general will have some sort of sexual dysfunction. And with my types of patients who have pelvic issues, 70% of them will have it. So a lot of women are out there with problems of this nature.
So you're a surgeon and you do, a lot of your work is sexual pelvic floor disorders, but part of that contributes to sexual dysfunction, right?
Absolutely.
Is that the only type of sexual dysfunction? Are there categories of sexual dysfunction?
There are. There are 4 categories, actually. They include desire, which is also known as libido, and there is arousal issues, there's orgasm issues, and there's even pain disorders with sexual function.
Okay, so when women start to have any of these, how do you approach it? Do they run to their doctor as soon as they feel their libido's decreasing or they're having arousal problems? How do you approach all this? Do you tell them see your family doctor first, or should they do things at home first? What is the approach?
I think the most important thing is when they feel they have a problem is to talk to a medical professional about it. Most common, it's easiest to talk to your primary care physician, since that's the doctor you usually have the best relationship with and feel most comfortable speaking about this. And they can give you some guidelines. They can talk about whatever medications you're on that may be causing that or worsening your symptoms, and they can give you some guidance. But in general, it's also important to talk to your partner, and if there's a problem with desire, arousal, maybe changing things in your sexual life, but having a conversation with both your partner as well as the medical professional in your life.
So should they look at their own life first and say, I'm taking these supplements, or eating differently, or what kind of things could they start thinking of on their own? Are there any supplements that would change your libido or any lifestyle changes?
Well, there are a lot of medications that can change your sexual desire and arousal as well. There are a lot of medicines that are commonly taken for a lot of medical problems, high blood pressure medications, diuretics, beta blockers, clonidine, which is a different type of hypertensive medicine, are known to cause problems with arousal. Medicines for reflux, for heartburn, Tagamet, the different H2 blockers can also cause effects. Antidepressants, medications can also cause problems with it, and even anticholinergics, which are medicines a lot of my patients take for overactive bladder.
So anticholinergics, what would an example of that be?
Things like oxybutynin, Detrol, Vesicare, lots of different medicines out there can cause problems. So I think looking in your own medicine cabinet and not necessarily stopping them, but talking to your doctor about it. I wouldn't ever recommend a patient stop their high blood pressure medication on their own because of their sexual arousal issues. It's important to talk to your doctor and see if that's a problem, see if they can change medication safely for you.
Well, I find that like half the people over 50 take some kind of sleep aid because it's the biggest complaint they come in with, even though I see them for heart problems. Are there common sleep medicines that really cause a problem?
Some of the sleep medications can. Twofold. One is, yes, it can just decrease your arousal, but also it can decrease your desire because you're falling asleep a little earlier before it's time to have, intimacy with your partner. So it's a little
better to be awake while you're having sex, right?
Usually.
So what about so they go to their doctor and they're going to do what are they going to look for? Diabetes or thyroid? What kind of problems would you think cause?
Medically,
basic stuff.
Yes, medically they're going to look for underlying diseases. Diabetes, thyroid disease are very, very common problems that would cause problems with sexual function. High blood pressure, heart disease as well, depression. All of these things can cause problems. So they'll look at these first.
Okay, so they do that stuff and they don't find diabetes, blood pressure problems, thyroid problems, and then do they stop there, or is there a team approach or something that can get them to the next level for arousal or for libido problems?
It's a good question. I think if these first questions are being entertained by their internist, their primary care physician, the next step would be to see a gynecologist or a specialist who can do a little bit further workup. For women, a lot of gynecological problems can make changes. When a woman reaches menopause, they can have changes in the vaginal region, which will be a definite component to their sexual dysfunction. They can have underlying pain syndromes in the pelvis. They can have problems problems I deal with, such as prolapse, incontinence of the bladder or bowel, which will also impact on your sexual function.
So if they're menopausal, would any kind of hormone replacement, testosterone, estrogen, does any of that help?
It's a good question. For libido, sexual desire, testosterone is a general treatment for women, but it is not FDA approved for women. It is FDA approved for men. We've found that even if a woman had normal levels of testosterone, they can still have a problem and be treated with testosterone successfully. However, there are a lot of side effects for a woman taking excessive levels of male hormone. So it's always good to start with estrogen therapy, particularly in the vagina, because after menopause, the tissues change. There's less blood flow, there's less nerve function, things are thinner and drier. And with estrogen, it kind of brings things back to what they used to be, and then with the blood flow increase, with the nerve function normalized, it can help you with all of these sexual dysfunction issues.
Okay, so for most women, they would take a tablet or a patch for their estrogen, but if they have sexual dysfunction, perhaps they would use a vaginal cream or something like that with estrogen.
Yes, either one could potentially help. We do know local treatment of the vagina works better than the hormonal replacement therapy women typically take for hot flushes and night sweats.
Oh, I see, okay. And then what about the problem, you also mentioned two other categories. One was orgasms. Is it expected that every woman should have an orgasm? I mean, is that expected or not? It's too complicated, huh?
And it's interesting, about 20% of women can actually won't have an orgasm with their partner, and they need to do it on their own. And there's also a small portion of women who have never had an orgasm. And when we talk about sexual dysfunction, a main component of it is personal distress. If a woman, say she doesn't have an orgasm, but it doesn't cause her distress, she has her husband, they have an intimate relationship, she is fulfilled and feels satisfied, and it's a healthy relationship without an orgasm, then it's actually not considered a problem.
Okay. So it's a little different than maybe in men, perhaps? I don't know.
Yes. Women are a little more complex than a man. We always joke about, for a man, for sexual function, it's kind of like a light switch. You turn it on, you turn it off. For a woman, it's a lot more complex, and there are different components to a woman being sexually satisfied: their own body image, their relationship with their partner, their medical problems, their stressors in their life, and just different components that really come together to make a woman sexually satisfied. And orgasm doesn't necessarily have to be a part of that to make them feel happy.
Okay. And then I guess the last category, which seems a little bit more problematic, is pain. So what are the usual causes of pain on intercourse?
Yes, a woman can have pain with intercourse for a few different reasons. Dyspareunia is when a woman has pain with sex for different reasons, where the muscles can be tender or whatnot, or there can be underlying disease such as endometriosis, which is just causing the organs nearby not to move, so it makes it difficult and painful with the activity. Vaginismus is when the actual pelvic muscles spasm, and it's much more discomfort for the woman at times. For either of these problems, it is still a team approach, because when you're having pelvic pain and pain with intercourse, you need to talk to your partner about it. You usually need a therapist so you can both feel comfortable talking about what approaches you can use to make things less uncomfortable. There's topical medications we can use as well, estrogen creams, even topical pain medications to help them. Physical therapy is huge, pelvic floor physical therapy, where a specialist can help with those muscular problems. But again, lots of different people to help with this.
We're almost out of time, so I guess the bottom line would be you can do something about this. You don't have to really suffer in silence anymore, right? There are people like you and a team. So would you say that somebody like you is the last resort, or are you really the gatekeeper to this whole approach?
It's a good question. Again, I think it's whatever physician you're the most comfortable with, because they're going to be the ones, like you said, the gatekeeper, who are going to manage the team that's going to be working with you. Again, there's going to be the therapist, the physical therapist, any internist, and your partner. Your partner usually comes to you with most of your sessions if feasible. And for me, with what I deal with pelvic floor issues, most of the women have the problem, so I'm helping to coordinate everything for them. But if they have a good relationship with their gynecologist or their primary care, it's really just about feeling comfortable with who you're talking about this with.
It was a great topic. Thank you for coming. I think we've learned a lot. I appreciate it very much.
Thank you for having me.